Mukamel, who's a professor at the Department of Medicine. Oh, sorry, I forgot to start recording as well. but let me redo that. All right, so I have the pleasure today of introducing Dr. Mukamel, who is a professor at the Department of Medicine with the Joint Appointments in Public Health and Nursing at the University of California, Irvine. She's also the director of the ITEQC, ITEC research program for translational technology enhancing high quality care. Her research focuses on quality of care, development of quality measures, quality report cards, and studies of market incentives and government policies and regulations leading to high quality of care. She's an expert in quality measures using big data and quality report cards. Much of her work focuses on long-term care settings and care for the elderly. She also develops mHealth apps to improve care in general and patients' decision-making in particular, emphasizing the importance of preferences and personal choice in medical decision-making. Dr. Mukamel's extensive research with over 200 peer-reviewed publications is funded by NIH, HRQ, PCORI, and private foundations. She serves on many national advisory and review boards, including CMS, AHRQ, and MedPAC, expert panels, as well as journals, editorial review boards as well. Her work has been recognized by a large number of awards, including the Lifetime Achievement Award from the APHA. She holds a BS degree in chemistry from Tel Aviv University, Israel, and a MS degree in technology and policy from MIT, and a PhD in economics from the University of Rochester. Welcome.
And I can share now my screen.
Yes.
Thank you, and thank you very much for this nice introduction. And hopefully I'll manage to find my presentation. Is everybody seeing it?
Yes, we are.
Okay. Technology is working. Okay. So we are going to talk about quality report cards and value-based purchasing as promised. And I need to do something else. Hold on just a minute. How do I get to my... What is my... I'm sorry, technology is not working that well.
If it's easier, Dr. Mukamel, I could run your slides and you just tell me when to advance. Would that be helpful?
Please do. I'm going to stop.
So stop sharing now and then I'll go ahead and launch it.
Please do.
No problem.
I was so happy. I thought it was working.
That's okay. Technology is technology is technology. So
yeah.
It's totally fine. All right.
Okay, next. Yeah, okay, great. So we're going to talk about quality report card, quality of healthcare, and I'm going to focus on it from the perspective of the patient rather than the perspective of the provider, of the physician or the hospital. And so I'd like you to put that hat on your head. And that would lead us to quality report cards, what's good about them, the bad and the ugly, if you remember that movie. And then that would lead us to talking about pay for performance, or as it's called these days, value-based purchasing. Next, please. So what are the challenges with quality of care for patients? Next, please. And this, I think, is one of our survey questions. Do you think that it is more difficult for the average patient to assess the quality of care of their doctor than the quality of my teaching you today.
So the poll is live. I have shared my screen so the students can toggle between the two. And everyone says yes.
Despite my fiasco with technology. Okay, so let's proceed. So we all learn how to be consumers from an early age. Next. And by the time we get to be adults, you know, we go shopping, we know which cheeses we like, we know which wine we like, and it's all based on our experiences. Next, please. And, you know, if we go shopping for clothing, you know, we can feel the material, we can tell whether it's good quality, it's high quality, we can look at the themes. We do it so often that we are experienced shoppers. Next, please. But when it comes to broken hearts, unfortunately, well, perhaps fortunately, we don't really have a lot of experience. If we need CABG surgery, we don't have experience. We don't know what a good doctor is or what a good hospital is. How are we going to figure it out? Next, please. So why is it so different to assess the quality of healthcare than it is of other services? Reese?
So we have one response so far, waiting for others. Okay, looks like we have about 5, so I'll start to. So it looks like most people think that most people do not have enough medical knowledge to judge in terms of differentiating between services. We do have a couple votes for most patients do not have enough experience with it in terms of assessing quality of services. And then the other 2 also received 1 vote with one cannot infer quality from observation of outcomes, and then outcomes may depend on luck, not just provider quality of care.
Well, that person probably sat in my class. So can we have the next survey? Well, you were all right, because this, if we try to sort of think about a model of how one would think about producing an output, if you will, of health encounters. And let's talk specifically about a heart attack. The outcome that we are all interested as patients is survival, right? I mean, that's what we care about. We all would like to survive a heart attack. And what are the inputs that go into producing survival? Well, first of all, we as the patients, we bring to the table all our risks, our age, our comorbidities, whether or not we had a prior heart attack. And for those of you who are physicians or physicians-to-be, you probably know what all those comorbidities are. And then everything that the physicians and the nurses and everything else that gets done to the patient in the hospital. And I like to think about all of this as one big box that I call quality. And in one hospital, different things or different combination of things will be done. And that would lead to the different levels of quality. And then, of course, there is the element of chance, because even with the best quality, some patients, unfortunately, will not survive. And even with bad quality, some patients will be lucky enough to survive. So if we try to present this as sort of an equation, we can say that outcome is some function of patient risks and quality and some element of chance. Next, please. So we could write this equation, and if chance were 0, as I have on the number 1, it wouldn't be difficult to just take this equation and calculate quality, if you will, as a function of the outcome, which we can observe, right? Survival or no survival, minus a function of patient risks. But unfortunately, we know the chance is not zero. So what do we do? Next, please. The implication of that is that, first of all, we need a large sample of patients, because chance means that it's random. So if we have a large number of patients, the element of chance will cancel itself out and it will be zero. So if we have data about, say, 100 or 1,000 patients who were seen in the hospital and had a heart attack, we can look at the risk-adjusted mortality rate and compare it to another hospital with its risk-adjusted mortality rate, and be pretty sure that this is really a reflection of the hospital's quality of care. It also means that we need to know something about the patient's risk, because as one cardiac surgeon once told me, that if you do your surgery only on patients who have only warts, nobody is going to die. So clearly you need to have information about patient risks. So the bottom line is that patients cannot rely on anecdotal observations. If my neighbor came back from a heart attack and survived, I cannot infer from that that the hospital my neighbor went to is a great hospital, and that's where I should go to if I had a heart attack. And therefore, individuals cannot assess quality by themselves. They need help. Next, please. So how are patients going to get information about quality of providers? I think we have another survey now, right?
Yes, we do. Looks like we have about 5 people that have answered. Give them some more time for more input. All right, let's show the results. So we have about 45% say most people, 50% now say that most patients get information just from asking people that they know. Another 30% say ask for referral. And then C and D trust their luck and assume that the hospital is good because of their insurance listed it. Each got 1 vote.
Okay. Well, let's see what I have on my slide. Reputation. Ask people that you know. Yeah, that's what people used to do. If they were lucky, let's say they had a physician or a nurse in their family, they had somebody who knew something, that was great. But you know, if you were to ask me and I don't know anyone, how would I be able to tell you? We know that there were other ways that people were looking for what we call signals for quality. So for example, they were looking at what we call hotel quality, those things that people can observe. So for example, for nursing homes, you could go in and take a look and see if the place is clean. You can observe the other residents in the nursing home. Do they look clean? Do they look like they are taken good care of? Do they look, does the place smell? I remember talking to a nursing home regulator probably 10, 15 years ago, and she told me that they used to have the nose smell. If the place smelled of urine, they knew that the place was not a good place. You wouldn't want to send your relative there. So people often think that if the hospital looks well, if it looks good, taken care of, if it's in a good neighborhood, if the clinic is in a good neighborhood, they assume that the clinical quality is also good. Another indicator of quality that people often assume is price. And that's a corollary that we make from other areas of our life. We know that expensive cars are also high quality cars, right? We know that expensive art is high quality art. We know that expensive clothing are high quality clothing. So we also assume that high quality physicians, that experts, would be the ones who charge more money. So a physician who charges more is assumed to be a higher quality or a bigger expert, so to speak, than a physician who doesn't charge as much. Experience, where the physician went to school, how many years are they practicing, which hospital they are practicing in. Those are often considered signals for quality. And for hospitals, a medical school where all the inventions, all the research is being done is often considered a signal for quality. So people were looking for all sorts of things that they could observe because they really didn't have a way to get at how many people were dying of a heart attack, because that information was not available. Next. So the bottom line is that people need help when they are shopping for quality healthcare. Next, please. And what do we do when we shop for cars? I need help when I shop for a car because I know nothing about cars. Next, please. Well, luckily for cars, we have the consumer reports. Every time I need a new car, I actually go and look at the consumer report issue for cars. So next, please. Luckily, it started in the 1990s. We started having consumer reports, so to speak, or quality report cards for healthcare. It started with New York State with the CABG report card, and now we have report cards for all areas of healthcare. So the question is, what should be the dimensions or what information should a quality report card in medical care have? And do we have a survey on that?
Yeah, so it looks like we have pretty split responses between physicians who listen to the patients, high survival rates after surgery, no complications from treatments. And then we still have some votes for friendly staff and all kids with immunizations, but to a less degree.
Okay, so let me tell you, you are all right, all correct. If you look at the quality report card that we have today, most of them have both of these type. I call these all those things about friendly staff and physicians who listen to the patients and so on and so forth, the things that patients can easily assess on their own. I call them the hotel or amenities. If you look at this slide, you see that I have two dimensions here. The one on the top is the observability, the things that patients can observe relatively easy on their own. So these are the physician is friendly, the nurses are friendly, they listen to you, and so on and so forth. So that's the hotel and amenities type factors. The clinical factors, that's whether the patient dies, pressure sores if you're in a nursing home, pain, all those clinical things that require risk adjustment and require statistical adjustment are things that patients cannot assess on their own. And those are the things that patients really need help with. And as you can see, And this is really where report cards started early on, because that's really where the value added for report cards is. Of course, it's important for patients to also know if the physician is friendly or not, but that's something you could ask your neighbor. And in the days when we didn't have report cards, that's what people used to do. And you would ask your neighbor, and your neighbor would tell you, yes, this physician, you don't want to go to him because he never talks to you, but that physician is wonderful. You should go to him. He spends an hour whenever you go to him. The other dimensions, the input and outputs, those are the 3 dimensions that Donna Bedian, who is considered if you haven't heard of him, he's the father of quality assessment. And in the 1980s, he proposed these 3 dimensions of quality assessment: the structure, process, and outcome. Structure has to do with things like how many nurses per patient a hospital or a nursing home would have. The committees, the M&M committee, for example, does a hospital have it or not? And how does it operate? Looking at agendas and how effective it is. The process are all those things that get done to the patients. Probably the sort of things that you've heard about in your previous lecture. And the outcomes are really the things that patients care about. Oh, no, I'm not ready for the next one yet. It's the risk-adjusted mortality, the falls with injury. So my argument would be, well, the value added of a report card is really at that corner where the arrow leads to, because it's the outcomes that patients care about, and it's the clinical measures that they really cannot assess on their own. So as I said, initially, when report cards were started, that's where they started, with clinical measures and outcomes. These days, as report cards have evolved, we also have the more observable measures, and we are getting into process and structural measures. Now you can go to the next one. So we have a lot of report cards in the US these days, over 150. They are publicly published, and the beauty of it is that it allows consumers to compare providers in the same area. So if you wanted to choose a hospital or a home health agency in Irvine, you could look at all those in the same area and decide on the one that you wanted to go to. Next. Next. The federal government has, this is the report cards that are the most known and well used. It's the Compare series. They have it about nursing home, hospitals, home health agencies, health plans, etc. And this is now established by law. The Healthcare, the Affordable Care Act actually requires CMS to publish these report cards. So it's no longer, unless they get rid of the bill, this is now part, and they have to do that. As I said, the New York State cardiac surgery reports were the first and are still considered to be the gold standard. And the private sector also publishes report cards. HEDIS is for health plan. I'm sure you've heard about the US News and World Report. It publishes a report card about hospitals, and UCI always is proud to announce how well we are doing. Next. This is, now I'm going to show you a few examples. This is an example of a California report card for physicians. It doesn't have a lot of specialties in it, I think only 4. And as you can see, it's based on claims data. And as you can see, there's not always data for all measures. So for example, this is for physicians who treat, the specialty is internal medicine, but this particular measure is about diabetes. And as you can see, not all measures this particular physician had enough patients to provide statistically significant results. So if the sample is small, they do not publish it. And physicians can get up to 4 stars. Next. And by the way, all the report cards are on the web. So if you're interested, just go on the web and you'll find it. Next slide, please. This is the compare series. Next, please. So this is hospital compare. You go in, and if you want to find it, just Google hospital compare and add the word CMS, because now there are a lot of vendors who manipulate the data and you'll get lost in it. So add CMS. You put in your zip code or the city you're in, and next, please. And this is just an example. There are now about 30 different quality measures. So there's a lot of information. I just happened to choose history of polyps received after a colonoscopy in the appropriate time frame. You always can compare up to 3 hospitals and you get the state average and the national average. You can also get it in tabular form. Next, please. And there are explanations. So you see, you can click on why. It's very, they're trying to make it very user-friendly to people who are lay persons, so who don't understand what's the meaning of the measure. And I mean, they even explain to you whether a high percent is good or a low percent is good, because some measures go in different directions. This is an example from home health agencies. Again, you have 3 agencies, state and national, and as you can see, the measures are very different. For example, how often patients got better at walking, because that's what's relevant for home health. Next, please. This is from nursing homes, and again, you can see very different measures. These are staffing levels measures. But again, there are probably around 30 different measures, and including clinical measures, which have to do with pain, not mortality, because for nursing homes, mortality is expected, but you have pain and pressure sores and depression and so on and so forth. Next. Now you can imagine that when you have a report card that has about 30 different measures, and as we found, and as it turns out, those are not correlated. So it's very difficult, which means that there's really no one best nursing home or no one best hospital. Each institution excels in one particular area, but might be average or even below average in another. So a hospital, say, that is great in heart surgery may not be great at obstetrics or in orthopedics. And similarly for nursing homes, they may be good at treating depression, but may not be good at improving ADLs, activities of daily living. So in 2008, Congress required CMS to develop the 5-star measure, the 5-star system, and they started it out with nursing homes. I call it the ZAGAT for nursing homes. And actually what they did was develop 4 measures for 5-star, because there was even no correlation between those. And the 5-star is given to those who are above average. 1 star is for those who are way below average. And there is an overall rating, a rating for health inspections, for staffing, and for the clinical quality measures. And as you can see, you can have 5-star on quality on the clinical quality measures, but have only 2 stars on the staffing level. So there are a lot of issues with these measures. Next. So as I said, these were developed because the individual measures are not correlated. And as I said, a nursing home that excels in one thing may not be excelling in another. So, next. So, do report cards matter? And there have been by now quite a lot of studies that have shown that they do. This is taken from a study that we've done a long time ago. One of the very first studies, or probably the first study that has shown that they do. And we've done it on the CABG report card in New York State. We have shown that, first of all, the information about, we've done it on the physician, on the cardiac surgeons. And we've shown that the referrals we've compared the year prior to publication of the report card to the first year that it was published. And we've shown that those surgeons who had better reported outcomes in the year it was published, their referrals have increased by 6%. So there was a very large increase in the odds ratio because of the information published in the report card, which is exactly what we expected. But there was one other finding that was also very interesting. Remember, we talked about those signals at the very beginning that people have been using before they had report card, and we talked about people using prices and experience of the physician or the surgeon. So we measured that both in the year, how those affected referrals in the year before the report card was available, and then the year after the report card was available. So before report card was available, really that was all that patients could rely on. In the year after, they now had, excuse me, much better, much more accurate information about the quality of the surgeons. And lo and behold, the importance of these two factors, the surgeon experience and the surgeon price, declined by half. They became half as important. So what this told us was that once people had access to information that was regarded as much more accurate, if you will, people relied on the report card and didn't pay as much attention to those signals, to the experience and the price, which I thought was very interesting. Next slide. But it turns out, like with everything else in life, that report cards not only have the impact that you expect them to have, they also have what we call unintended consequences. And an example is what happened with Nursing Home Compare. One of the measures is a measure of pain. It's based on what percent of patients experience pain at day 14 after they're admitted to the nursing home. Now, this measure is not risk adjusted. So what do you think happened? Well, nursing home administrators and clinicians are not stupid. If they wanted to have this measure lowered, what they did was to ship those patients who they predicted would be with pain on day 14 to the hospital, so that they will not count on day 14 towards this measure. So Konecka et al. Did a study and found indeed that, and again, they compared nursing homes in a period before this measure was employed and a period after this measure was employed, and they found that there was an increase in hospitalization of patients at risk for pain once this measure was deployed. They estimated that this increased hospitalization ended up costing CMS $1 billion nationally. And they didn't do any estimates about quality, but we know that hospitals are a really bad place for nursing home patients. So just imagine shipping all those patients to hospital just because of a quality measure that was not done well and not thought through completely. Next slide. So this is a summary of the impact of report card. We did a review paper, this is from 2014. Now, report card, as I said, started in the 1990s. There were many more of them through the 2000s. So by that time, there were quite a few studies. We found 65 studies in all. And the numbers in parentheses are the percents of studies that found significant effects of the specific effects that we were studying. So 71% of the studies that looked for referral effects found them. 81% of the studies that looked for functional responses, like the one that I mentioned to you, the one where referrals were responding to prices, found them. 64% of the studies that looked for the studies of unintended consequences found them. And 100% of the studies that looked for financial impact on providers found them. Those were studies that looked for whether or not providers that had better scores also had more revenues or more profits, and they all found them. So all in all, 78% of the studies found that report cards had an impact on the market, on the way behavior of patients, providers, and so on. So they seem to really do matter, at least more than 3/4 of the time. Next. So now I want to go back for a few minutes to the 5-star. Remember, we talked about those. Next. This is the same slide we've seen before, just to remind you. If we can go next slide, please. That's for nursing homes. And remember, I told you that the actual quality measures are not correlated. So if one had to choose a nursing home based on them, they would drive you into all. It would be very difficult to make a choice. Next. Next slide. Oh, basically that's the reason for choosing a 5-star. Next slide. So when the quality, as I said before, when the dimensions are not correlated, there is no one best nursing home. Next slide. So the 5-star, the way it was constructed, basically CMS got together a task force, a panel of experts. I happen to be one of them. And basically these 10 people sat around the table, and based on our understanding of what is important and what is more important, what is less important, we chose which quality measures to include in that 5-star statistic and what are the relative weights. Now, this is the opinion of A, of experts, and B, it's a one-size-fits-all. And as we kept thinking about it, I was wondering if that's really appropriate, if that would really be appropriate for all patients. And that's led to this project that we've done here at UCI with a large grant from AHRQ, in which we developed a decision aid that allowed each patient to develop their own personal 5-star based on their own needs and preferences. And by the way, we are now working with case management here to actually bring it into regular care. So this is the first slide that they would see when they turn on the app. It sits on an iPad. Next slide, please. And I'm not going to show you everything, but this is the main slide or the game of the decision aid. Basically, here you can see all the quality measures. And what the user does is they choose those that are important to them. So if they care about nursing staff, as you can see, they pull it down to the visual scale, and this particular person thought it was very important, so they moved it down to almost to 10. And then state inspection, they moved down to between the 8 and the 9, and so on and so forth. But they didn't choose everything. Then what the app does, it takes this information and creates something like, it creates a score that is for the individual. And it then provides the individual with a list of nursing homes that are sorted based on the individual score that the individual that came out of this ranking of the individual. There are all sorts of bells and whistles. They can also, we let them go and look at the web page of the nursing home. We show them the CMS 5-star so they can compare the two, and so on and so forth. Next slide, please. But basically the idea is to match the patient needs to what the nursing home excels in, and do it, and it's a personal match, unlike the CMS 5-star, which is a one-size-fits-all. Next, please. Do we have a survey here?
Sorry, I was still muted. It should be active. I'm sharing my screen. Here we go. So it looks like we have about a 50-50 split. A little bit more people said they'd go with the personalized card.
Okay, so next slide, please. Well, let me show you the RCT results. When we compared the choices that patients made, we found that only in 1/3 of the cases, the personal choice would have been the same as the choice based on the 5-star. Next slide, please. In terms of satisfaction and confidence, the nursing, our personal aid did better than the 5-star. Next one, please. And when we compared the choices, or rather the nursing homes in which the users of Nursing Home Compare Plus ended up to those that did not get to use it, remember this was an RCT, they ended up in better nursing homes based on all measures, except for staffing, which was not significant, but still a better odds ratio. What was also very interesting, if you look at the very last column, hospital length of stay, they had a shorter length of stay than those who did not use the decision aid. This odds ratio translates to about a day and a half shorter. So that was very interesting because first of all, it meant a lot of savings for the hospital. This translated, if I remember correctly, to about $2.5 million a year for the hospital. But it also meant better quality of care for the patients because some of you might know that each day in the hospital carries with it a 10% probability of iatrogenic disease and infections. So every day that a patient can spend outside the hospital is better. And that was actually something that we didn't anticipate, although Dr. Amin, I wasn't even going to measure it, and it was Dr. Amin's idea to measure it, and look what we found. Next slide.
What do you think was part of the explanation for the shorter hospital stays?
Well, one of the things we found was that group, usually people go to visit the nursing home. This group did not made many fewer visits to the nursing home. So I think they felt more comfortable in their decision and did not have a need to go and visit. So that's one thing. Another thing is that the whole process, because of the way it was done, they got to start thinking about it and making choices earlier in the stay than the other group. So the whole thing was faster. And the third thing, and these are, all speculation on my part because we never asked about it, but I think that you saw that they were more confident. We found that they were more confident in their decision. So I think when you're more confident and when you feel that you're part of the decision, you can reach that decision faster. You don't have to second guess yourself and worry about it as much. You're more confident in making a decision. So I think that that's what happened.
That makes sense. Thank you.
Sure. But that's a question that we thought about it a lot, but unfortunately, by the time we saw the results, we were no longer in a position to ask the question. Okay, so this is it about report cards. Now let's talk in the few minutes that we have about value-based purchasing. Next, please. So report cards are about, let me first tell you what is value-based purchasing. Value-based purchasing is when the payers, insurers, measure provider performance, typically using the same measures that are reported in the report cards, and then they pay more to those providers who perform better and less to those who perform worse. Next. So what is the objective? Do we have a slide? Or maybe we should skip it just in the interest of time. Let's just go ahead. Next. So what's the objective? The objective is to incentivize, to provide incentives for higher quality care, just as quality report card. But with quality report card, it relies on the market to provide the incentives. And the market is noisy because basically it hopes that with report card, we are hoping that patients will see the report card and will vote with their feet. But patients have other considerations. We know that patients really worry about distance. They always want to go to the hospital or the physician that's close to where they live. They may have other considerations. They may want to go to a nursing home that, a friend of theirs is in that nursing home. And some patients may not even see the report card. So there is a lot of noise in that signal, so to speak. With payers, it's very clear. The payer calculates the measure and the payer makes the payment. So there is no noise. It's a much cleaner, clear signal. And the payer controls the size of the financial incentive. And that can be very minimal. Some of them are about 1% of revenue, or it can be large. In some instances, it's 8%. So that's what's behind it. Next. The incentive structure, in some cases, it's a financial report to those providers who are at the top. So it might be something like any providers who are at the top 10% will receive a reward. And sometimes it's a reward to those who improved relative to themselves. So it's either relative to the whole universe of providers, or sometimes it's a reward relative to your own prior year history. Now, both of these have disadvantages. If it's relative to the whole universe of providers, so only the top % gets it, those who are at the bottom might say to themselves, well, I'm at the bottom, there's no chance I'm gonna get to the top 10. I'm not gonna even bother. And if it's relative to your own performance last year, those at the top might say, well, I'm already at the top. It's very difficult and very costly for me to improve even more. I'm not gonna bother. So both of these have disadvantages. And the best approach, therefore, is actually a combination of the two. And some systems have indeed taken an approach that is a combination of the two. Next. The hospital-based purchasing started in 2013. It had several measures: healthcare-associated infections, mortality and complications, patient safety, patient experience, efficiency, and cost reduction. 2% of Medicare payment were at risk. Now, I'll be talking only about Medicare systems. Some private payers also have it, but that's all over the place. Turned out that it wasn't very successful. It did not lead to any improvement in 30 days risk-adjusted mortality, and it was not, they could not find any improvement in process measures or in patient experience, which is CABG, if you guys have heard about it. So it's no longer in play. There are now other types of value-based purchasing programs around. Next. Nursing home and home health, both are still in demonstration stages, but will be going into full national demonstrations in 23 for nursing home, 22 for home health. Nursing homes will be only 2% at risk, and it will be, for nursing home, will be based on both improvement and achievement. Remember how I talked about having both of these types, but it'll be only on one type of quality measure, hospital readmission rates. And you'll find often that this is the quality measure that CMS is focusing on, although remember there are like 30 different quality measures for nursing homes. And the reason is because for CMS, that's where the big money is. So that's really where they want to see a lot of improvement. For home health, it's going to start a year earlier, but we really, this was announced just a few months ago, but there were no details. So we really don't know whether it's going to look like the demonstration or not. The demonstration itself, it was interesting. It started with a 3% of revenues at risk, but each year it increased. And by 2022, I guess next year, or no, this year, it's going to be at 8% at risk. And this is, to my knowledge, the highest percent risk from all the demonstrations and all the value-based programs. The early years that have been evaluated have not shown much of an impact, but it will be interesting to see if there was actually improvement in the later years when there was much more money at risk. Next. So other types. For hospitals, well, it's not, okay, so now CMS is going towards value-based programs that involve more than one type of provider. So the bundle payment care improvement program was constructed around an episode, a clinical episode, when there were 48 of those. So basically what they did was to say, for example, if you have a joint replacement episode, they said all the providers that are providing care for that type of episode. So that means the physician, the surgeon, the hospital, nursing home, and home health. Everybody who touches the patient who requires that type of care have to get together in a risk arrangement. So there will be one payment. That's what is called a bundle payment. There's going to be one payment from CMS to the whole group. And the whole group has to provide all the services within that one capitated or one total payment and within a certain quality target. And what they found was, and as I said, there were 48 such special clinical conditions. And what they found was that it was really successful. It was less costly only for the lower extremity surgery joint replacement, but not for any of the other episodes such as cardiovascular or spinal fusions, although there were no differences in quality. So at least quality did not deteriorate, but there were no cost savings for CMS. So this has now been abandoned, and now there's a new model called BPCI advancement, which also is around clinical episodes with a target price. It sounds more complicated. To be honest, I'm not quite sure how this is going to work. So if you want more information, I suggest you go on the web. And we'll need to see how that works. And I think that this is the next, please. I think this is my, no. So by and large, value-based payment have not been shown to be successful. There is no one clear reason for that. One possibility is that the financial incentive may not have been sufficient. As I said, most of those programs have had low percents, except for the home health that went up to 8% in the last year. They were all around 1 or 2%, and that might not be sufficient. It's also possible that they have not been transparent enough, or that the formulas that are made up are so complex that it's difficult for the clinicians and the providers to see the linkages between what they do day to day to the financial incentives. So if it's too complicated, we can't really expect people to actually act on it. And finally, there is the issue of timing. Although nobody has really been talking about it, but in behavioral economics, there is some evidence to suggest, and this has not really been seen has not been tested in healthcare, but it seems that people in general do not react to incentives that are post hoc. It's much more effective if we pay people ahead of time, and then if they don't meet a target, they need to pay back. But none of the value-based payment programs or any of the financial incentive programs that we ever had was constructed that way. So that might be it. And I think that this is the last slide, right? Yes. So thank you very much. And I don't know if you have any time for questions, but I'll be glad to answer if anybody wants to stay or can stay. I don't know if you have another class now.
So I want to thank you, Dr. Mukamel, for giving us such an in-depth look at these things. I think it's always kind of annoying, honestly, to know that you had to demonstrate in the literature or by some study what we kind of already knew. We knew that financial incentives are not adequately aligned with care or quality. I think your last slide was actually one of the most necessary of the presentation, that what we've been hanging our hat on in terms of paying for value hasn't been proven to work in a lot of different senses. And I think it's necessary for us to have that context in order to act, right? I think it also paints a really necessary picture for us as future providers to say, hey, you're the patient, you're trying to find nursing home for mom. Here's how you actually go about doing that, right? That's not necessarily something that we're taught in medical education, and certainly not in undergraduate practice. So thank you for bringing that really necessary information to this space. Lecture feedback is up. If you do have questions, then we're going to invite you to drop them in the chat box, because we do have to move into our next session, or just shoot either Reese or I an email and we can connect you directly with Dr. Mukamel. She is an academician by every sense of the word, but also super approachable. So I want you to know that she can answer your questions when it comes to quality and how we measure it and how we approach it as the consumer. Thank you for being with us today, Dr. Mukamel.
My pleasure. And I'll be glad to answer questions if people want to email me. So
perfect.